Well, it's 7:15. Welcome everyone to sign out with the professor here for the late January edition. We hope that your new year has begun well. I'm Dr. Lewis Hassel. I'm at the University of Oklahoma, but I'm very pleased to welcome our guest today, Dr. Oyedele Adeyi from the University of Minnesota. He is the director of the director of anatomic pathology and a wonderful colleague. He has a number of cases from his area of passion, which is liver and biliary disease, that he's going to share with us. And as we have questions as we go along, please don't hesitate to type those into the chat, or if you would like, you can even unmute yourself and raise a question verbally. I'll also point out that for the February edition, we will also have a guest professor, a return engagement from my colleague Shweta Agarwal, who's at the University of New Mexico and in the process of moving to the Mayo Clinic. She'll be talking about sinonasal lesions, and that should be a very engaging program as well. So look for the announcement on that. So without any further ado, Dele, the floor is yours.
Yeah, thank you very much, Lewis, and good morning, everyone. I think some of you probably are in the afternoon already, so good afternoon or good evening, wherever you are. So thank you for taking the time to join us this morning. And like Dr. Lewis just said, if you have a question, you can stop me or just type it into the chat, and I will try and keep an eye on that so that we can address every question. So this topic today is just to mostly talk about terminologies as we sign out our liver diseases. And the preamble that I have there is just a form of introduction. So from my experience, when I get these medical liver biopsies, almost always there's a word there that says it's hepatitis. And sometimes people say, well, hepatitis, and then they clarify it. So I was just talking yesterday with one of my trainees, and we were talking about a case that was signed out as hepatitis consistent with PBC, primary biliary cholangitis. So there's something wrong with that already. It's either hepatitis or it's cholangitis. It cannot be both. So, but traditionally, a lot of people just use the word hepatitis as a buzzword for inflammation in the liver. So if you have that loose definition, that's okay, because that is the way you are using it. The problem is that the hepatologists that are looking at your report, they don't read it that way. So when they hear the word hepatitis, it means something specific to them. And so the way they will investigate the patient is going to be based on the understanding that this patient has hepatitis. They are not going to interpret and say, oh, hepatitis, but it's a bowel duct disease. So what I just want to show you today is how I've been able to use the right word, and the right phrase in your report is very, very important. And of course, it's going to include some basic understanding of what some of these diseases look like. So 1 hour is not such a long time to cover a broad topic. So I decided to just illustrate this morning with biliary diseases. And so we all remember that in the liver, we have different structures. Of course, the biggest cells in the liver are going to be the hepatocytes. So here we have an example of a liver that is not normal. It's our first case this morning, which is from a 53-year-old woman. But before we go into the story, I want to just point out that the largest volume of cells in the liver are the hepatocytes, which is what you see here. And I know that most of us here are pathology resident or pathologists, so I won't go too much into histology. I will assume that we've already seen some of this. And so the word hepatitis is actually named after injury to those cells. So when there is an inflammation or injury to the hepatocytes, we say there's hepatitis. But we always have to remember that there are other structures in the liver apart from the hepatocytes. So we have bile ducts in the liver. And so when you have injury against the bile duct, that makes it a cholangitis. It's not a hepatitis. And when you have injury to the blood vessels, which we also have in the liver, that would be a vasculitis. Now, you can begin to see how all those things can look very similar because the compartments are so, intimately intertwined. So when there's an inflammation against the bile duct, it just shows inflammation. So you have to figure out what is the target of the inflammation. And if you are not careful, you might think that, well, it's in the liver. Some of it is right into the interface, like what you see here. So that has to be hepatitis. And that is really what we want to talk about it. So if the inflammation is not directed against the hepatocytes, try to stay away from using the word hepatitis. And if you use that word, you want to clarify, to your colleagues that will be treating the patient exactly what you mean. But rather than putting it down and then clarifying later, my approach is to stay away from that word completely, unless it is what it is. So here is a 53-year-old woman who presented with itching. And on screening, she was found to have positive hepatitis B core antibody and negative hepatitis B surface antibody. So just from that, we know that we are probably not going to be dealing with viral hepatitis. So hepatitis B core antibody means that this woman had been exposed to hepatitis B at some point, but the negative surface antigen makes it unlikely that she currently has the disease. Now, her liver enzyme also do not look like we should be dealing with hepatitis. So even from the history, you can begin to start guessing what you are likely to see and what you are not likely to see in the biopsy. So if you look at the enzyme profile, the transaminases are essentially normal, 33 and 22. The alkaline phosphatase here is about 2 times the upper limit. So in our lab, the upper limit is about 140, 150. So 298 is pretty much 2x of that. The bilirubin is normal. I put positive F-actin there just to remind me to talk about that. So you're going to read that this is very specific for autoimmune hepatitis, but it is not. And this case is a very good example of that because she was really positive for F-actin and she doesn't even have hepatitis. So we are not going to be talking about whether it's autoimmune or not. Post-biopsy serologic data is available. And this goes to what I was just talking about, that the language you use is going to tell them how to investigate the patient. So based on the report of this biopsy, they did some studies that they didn't do before. So let's go through the biopsy. I'm hoping everybody can see the slide. So here at the University of Minnesota, we are very fortunate. We usually get, it's very uncommon that we will complain about the size of the biopsy. So the first thing you want to be sure you have is adequate biopsy sample, and this is quite adequate. And on low power, you see that there are some things that look like blue, right? And so there is some inflammation really in this liver. And you can look at all those there. So the first thing that catches my eye is that the inflammation is all sitting right in the portal tract, and that the portal tracts themselves are a little bit enlarged. And I'll just scan through and then come back to one of these to illustrate. So you find that this is just, every time you see anything busy, it's just right there in the portal tract. Now you can see hepatitis that is only portal inflammation, especially the very mild chronic hepatitis. There's no doubt about that. So that is what now takes you to go deep down and find out what the inflammation is doing. So this is another area where the inflammation is sitting right in the middle of the connective tissue, and you have a hepatic artery right there. And the other thing that you start noticing is that in this portal tract, there's really no bile duct at all. And you may appreciate some of these macrophages that obviously are cleaning up something that disappeared. But there's no bile duct there. But let's continue to scan through and just see what the inflammation is. So we established that we have some portal inflammation. And then the other thing to establish is that the portal tract is quite expanded. I hope my internet is not lagging behind. It shouldn't. Okay, so this is from our server, unfortunately. Okay, so now you find that the portal tracts are quite expanded, and this is one. And now when you go deep down, yes, there is inflammation, but you find out that what is expanding the portal tract is not the inflammation. And the way to calculate that is this. If you remove the inflammation from this portal tract, will this portal tract be less expanded And the answer clearly is no, because the proportion of inflammation there does not explain the expansion of that portal tract. So something else must be responsible for that expansion of the portal tract here, other than the inflammation. In the case of chronic hepatitis, when you see portal expansion, is because the inflammation is a lot, and inflammation is responsible for the expansion, where the portal tract goes beyond the limits of the limiting plate. So here's another very good example here of that inflammation. And again, you see that almost everywhere you see this loose connective, almost like a myxoid kind of a stroma there. And that's because the portal tract has some edema. And then the other thing that you see there are all these structures. So these are ductules. These are reactive ductules. And again, in this portal tract, I think maybe this may be the bile duct, but it's possible that the bile duct here is also missing. So we have portal expansion as a result of increased matrix, in this case, edema, increased ductules, a little bit of inflammation, and we'll go to the trichrome stain later and everything. So having looked at all this one, the chances are that I'm not dealing with inflammation that is targeted, that is interested in the hepatocyte. And another way to look at that is to look at the hepatocytes away from the portal tract, and you see how pretty much clean they are. So we have the history, we have the serology that doesn't show that there's significant hepatocellular injury here. We have the biochemistry that suggests that I should be looking at the biliary tree system. So alkaline phosphatase is a bile duct enzyme and a canalicular enzyme. So I have all those now, and I have the histology that's also supportive of that. So what is going on in this particular patient? This is what a biliary tree injury is going to look like. And I always like to look at biliary tree disease in two components. One, the small duct and the large duct. So let's start with the large duct disease. When you have an injury at the hilum, which is where the large ducts are, and you are getting a biopsy from the periphery, you are not going to see the actual injury because the biopsy is going right into the parenchyma. So it's impossible or it's unlikely that you are going to see the actual injury. But because of the smaller bile ducts, now having to struggle to continue to drain their bile through the large duct, there are going to be some changes that you see in the large duct. And you see some of those changes here, and that is some of the things that we've covered. So the small portal tracts become, enlarged, they become edematous. And if you see inflammation there, it's most likely going to be neutrophils there. So when I see portal expansion with neutrophils and edema and all those, in a patient, of course, we are always putting this on top of the biochemistry and the clinical presentation. I'm going to start thinking that there is a large duct disease. And the other thing that I would look for there is to look for the small ducts where the biopsy that is represented in the biopsy. Most of the time in the early stages, the small ducts are going to look okay because again, the injury is not at the level of the small ducts. So what you are seeing in your biopsy are going to be reactive changes to something that is happening more distally. This is a little bit different from that. Again, some of the changes you see here overlap. So you see the portal expansion, you see the edema. But in this case, you are struggling to find the small duct. So let's look at this portal tract. How do I know that the small duct is not there? So this is the hepatic artery. And usually the hepatic artery and the small duct, they go hand in hand. So the small duct should be somewhere here. I don't see it. What I see are this evidence that these macrophages are trying to clean up something that probably used to be there and no longer there. But I see some epithelial cells that look like bile ducts, and you see how they are hugging the interface and they're expanding. So these are reactive ductules. And I know that they are reactive ductules, one, because they are not accompanying that. Secondly, because most of them don't have clear lumen. Maybe one of them has a lumen here. And thirdly, where they are located right there at the interface. So those are what ductular reaction looks like when you find them. And that is contributing to the overall expansion of the portal tract. The other thing you see is that those ductules have actually gone right into the parenchyma because you can see the original interface hepatocytes. Here they are. It's like now they are sitting right in the middle of the portal tract. So you see it in expanded portal tract, and again, you don't really see the bile duct there. So the other thing, so if the bile duct have disappeared, then we don't really know what caused the disappearance. So what we want to do is to look around and see whether we can find an area where the bile duct is still there, and then we can define what is causing the injury. Unfortunately, in this patient, you don't see a lot of portal tracts with that. Again, this is the hepatic artery in this portal tract. Again, you see those macrophages, and so presumably this is where the bile duct was. And the bile duct has been taken out, and now you get these macrophages, right there and there. And again, as you go towards the edges, you are going to see some attempts to form new ducts and ductules at that point. The real bile duct you are looking for is the one that matches that hepatic artery. So the hepatic artery is a very good internal control for you to know what the bile duct should look like, what is the size of the bile duct, and where it should be located. So as I go through this biopsy, I don't really see, unfortunately, an actual bile duct that is still undergoing. So I think this is coming from the university server. Something is lagging. So I don't really see a bile duct that is still undergoing any kind of injury. Now, this patient ultimately has a primary biliary cholangitis, PBC, and she's lost a lot of bile duct. So let's talk about why we came to the conclusion of PBC in this case. We've already established that she has a biliary disease, and it's either a large duct or a small duct disease. Before the biopsy was done, because of the biochemistry, they had actually already done an MRCP, which was negative. So we know that. If we didn't know that, we would be suggesting to them to go and look at the MRCP, because if this patient had PSC, primary sclerosing cholangitis at the large duct, she could also lose some bile ducts, and the portal tract could look like this. So we already know that that is not there. So we are now left with the possibility that this patient has a chronic, large duct, small duct disease. Chronic because she's already having some fibrosis to go with the duct loss. So this is a trichrome stain, and again you can see what the portal tract looks like. You see, quite irregular and very variable. In areas you think that it's beginning to cause some breaching, but not so much. So she's got some fibrosis. So we know that this disease has been there for a while. And it's not a large duct disease, at least as far as the radiology is concerned. She's a middle-aged woman. She's got itching. And that's it. Those are all the things that you expect to find in a patient with primary biliary cholangitis, even though we don't see the actual lesion right now in this patient, but it's enough to suggest. So I said that this patient has a post-biopsy serologic data. And so they went there and they did all the serology that you would expect in primary biliary cholangitis, which in this case will be the mitochondrial antibody, specifically the M2 AMA, which is the specificity against the E2 subunit of the pyruvate dehydrogenase. And if you remember your biochemistry, you remember the pyruvate dehydrogenase is a Krebs cycle enzyme. And we know that Krebs cycle occurs in the mitochondria. So this is a big enzyme complex, pyruvate dehydrogenase. So the specificity in PBC is one of the subunits of that big enzyme, which is the E2 subunit. So we can be very specific, or you can just screen for antimitochondrial antibody in general. So this woman had positive antibodies, and she also has elevated IgM. So that's another thing I want you to take away, that most patients with PBC, almost always they have elevated IgM. That's total serum IgM. So it's a very important serology in addition to AMA. And even when the AMA is negative, which can occur in 5% of patients with PBC, IgM is always a very, very reliable surrogate to tell you that this patient probably has PBC. So we have a 53-year-old woman with a cholestatic liver enzymes that has a chronic biliary disease with some ductopenia and positive PBC serology. That essentially clinches the diagnosis. So, but if we didn't call the pattern of injury, they might not even know to start looking for those serologic enzymes. And it's quite important because it tells them the prognosis, it tells them what to do to this patient. PBC cannot be treated, and eventually the patient is probably going to develop cirrhosis. So the lifetime incidence of cirrhosis in PBC patient, I think, is about 60% of patients. Some, live with the disease and die, but the majority are likely going to go and end up with cirrhosis, and a subset of those will end up in transplant. A lot of hepatitis can be treated. So if you call it hepatitis, they're going to be looking for something to treat. And so that's another important reason to call it what it is. And even when you miscall it hepatitis, and this, it's waste time, eventually they will figure out that it's not hepatitis. And it's quite embarrassing when after a year or two of signing out a case, somebody sends it back to you and say, oh yeah, I should have told you it's PBC, not hepatitis. By that time, a lot of money has been spent. The patient has been frustrated, not knowing what is wrong with her. And ultimately, somebody comes back and says, oh, yeah, we should have told you last year that you had PBC. And of course, they have things to give them to make them better from the itching. So PBC, itching is actually one of the first symptoms, of PBC because of the retention of the bowel salt. So they can treat that and symptomatically, and they can do a lot of things that will make the patient better. But importantly, the patient at least has a closure. Now, I'm showing you the second case on the list, which is actually from the same patient. And this is 3 years later. And now you see that this is more or less the same thing. And I just wanted to touch on the context or on the concept of the reactive ductus. When you take out the native bile ducts in primary biliary cholangitis, the stem cell is still able to respond. And so stem cells respond to cholestasis or cholestasis within the liver. And so here you start seeing the liver trying to make more ducts. And for some of you who have access to the very, very old PBC literature, one thing you remember is that when we tried to stage PBC, the presence of ductular reaction was actually one of the features. And I don't know whether it was stage 1 or stage 2. But that, of course, we don't do that anymore because we realize that at every stage of the diseases, you can see different degree of ductular reaction. So here again, it still looks like this patient has a lot of inflammation. But as you go down, you find that there's really not a whole lot of inflammation right there. What you see here, there is inflammation, all right, but what you see there are just a mixture of reactive ductus against this, some edema, and now you see the hepatocytes look like they are now right in the center of the portal tract. And that's because the portal tract itself is expanding out towards the lobule in this case. And as you go down, you find out that the trichrome is showing that the fibrosis in this woman has actually progressed, which is what happens invariably with PBC. Now she's got more broad fibrosis here, very, very thick, dense fibrosis. Now you are beginning to see some nodules. Now that takes us to the context of, so if we were seeing this woman for the first time now, if this was to be the first biopsy instead of the first one we see, we will still call this a biliary disease. But now we are beginning to see something that you will have come across that we call the biliary type fibrosis. And this is what it looks like. So it tends to have this dense, broad septate that is bridging. In cases of hepatitis, when you see this broad, this very thick fibrosis, you are dealing with very advanced cirrhosis already, if this was from hepatitis. And in those cases, you are not going to be able to see the architecture of the liver anymore. So you see the fibrous, and then everything inside it is nodule. But look at this. Despite the broadness of the fibrosis, I can still tell where the hepatic vein is, right? So that is zone 3. which you are not going to see in other diseases that are not biliary disease. So what happens here is that because the disease is biliary, the fibrosis develops and starts bridging portal tracts with portal tracts. It's much, much later before the overall architecture becomes effaced. So if you still look at it, you are going to see, a lot of, maybe a little bit here. You're still going to be able to see the central vein. So if somebody sends me a report and says, oh, this patient is cirrhotic, and I see the inflammation in zone 3, that cannot be right, because in cirrhosis, you don't get zones anymore. You get just nodules. So when you are still there, you see a lot of fibrosis and you have not effaced the overall architecture. Think you might be dealing with a biliary pattern fibrosis. And that has a different thing. So I can say this is stage 4 fibrosis and I'll be right. But stage 4 fibrosis in this case does not mean stage 4 in other diseases. And again, that is why it is important to characterize it. So if I tell the surgeon and say, oh, it's got a lot of fibrosis, but it's a biliary pattern, that means to them that, okay, maybe we don't have to start looking for hepatitis B, for hepatocellular screening. This patient is not going to be functionally decompensated. She's just going to continue to become jaundiced and she's not going to be able to drain bad. So most patients that, well, not most, a lot of patients that ended up in transplant because of PBC, they actually end up in transplant because of quality of life, not because of cirrhosis. And the quality of life is because they lose so many ducts and the fibrosis follows the duct loss. Okay, so the more ductopenia there is, the more the fibrosis that you are going to see in this patient. And that will be the reason why. So the thinking process, the approach, the workup, the prognosis is completely different in biliary diseases than it is in hepatitis. So I see some questions here. Say, what scheme do you use for grading fibrosis in PBC? Ishak? No, I don't use Ishak. I will come back to that. Please recall the specific antibody for PBC. So that is the E2, so antibody directed against the E2 subunit of the pyruvate dehydrogenase, which is one of the mitochondrial antibodies in the body. So the large enzyme is pyruvate dehydrogenase, and the specific subunit is what we call the E2, E as in echo. Now back to the grading and the staging system for PBC. Some people use Ishak and it's okay, but I don't use Ishak. I use any one of the 4-stage score. But I will call your attention to a paper by Dr. Nakamura from Japan. Many of you know, and I will find that reference and share it with you. I will follow her approach. So basically, the staging in this case is to quantify the ductopenia and to stage the fibrosis. So in this case, our report will look like chronic biliary disease in keeping with primary biliary cholangitis with severe ductopenia. So I don't have time to go through all the bile ducts one by one to show you that there's hardly any small ducts left in this patient. So I'll say the severe ductopenia, and I'll probably give a percentage, maybe 60, 70% with LINEC. So we use LINEC, which is a modified metravir, and I will say LINEC stage 4. Stage 4B with a biliary pattern. So we now know, and again, when you read the Nakamura paper, it shows you why, that the ductopenia and fibrosis, they are more linear and they predict with more linearity, the progression of this. Yeah, E2 subunit. So that's the one, the pyruvate dehydrogenase. Thanks, Lewis. Okay, so that's what I use to stage PBC. Notice that we don't grade PBC, right? So we stage. And that's because, again, the nature of the disease, it starts in a very patchy way. If you see a lot of floridot very early on, then you can say that, there's a lot of floridot. There's another variant of PBC that we are beginning to recognize, which we won't cover today, but if you are interested, you can look at it and say rapid ductopenic PBC. And that is one that the ductopenia occurs very rapidly, and it takes a long while for fibrosis to catch up. So you see the ductopenia is out of sync with fibrosis. Okay, so that is the first case, which I just put side to side. So it shows you the biopsy from PBC with the linear progression to more advanced fibrosis. Eventually, this woman is going to probably require, liver transplantation. Okay, so let's go quickly to the last three slides. So here we have a 47-year-old woman. Oh yeah, this was actually one of my recent and favorite cases. So she's been treated for rheumatoid arthritis. She presented somewhere during that treatment with jaundice and was found to have cholestatic liver injury, which from the clinician point of view, this is the definition of cholestatic liver injury, meaning that it's mostly an alkaline phosphatase. So I'm not showing you the gamma GT here, but the gamma GT in this patient was like over 1,000. And now you see the bilirubin here is rising up. And I know this is an international audience, so and some of us use micromole. Some of us in the US, we still use milligram per deciliter. So whichever one you are used to, you see that the bilirubin there is quite high. The IgG is quite normal, total IgG, and again, autoimmune serology. I was talking about IgM in PBC. In autoimmune hepatitis is almost unlikely. Well, let me put this very well. It's very unusual that you are going to have untreated autoimmune hepatitis with normal serum IgG. So that is actually more specific than the ANA and the F-actin and everything. So a lot of people have ANA that don't have autoimmune hepatitis. Some people have F-actin, they don't have autoimmune hepatitis. But there are very few diseases that will give you isolated IgG elevation. And when I say isolated, usually about 2 times the upper limit of normal. Maybe sometimes 1.5, some up to 2. I've seen it up to 3 times. When you see that in a patient with a hepatitic profile, you are probably dealing with autoimmune hepatitis until proven otherwise. But in this woman, she has more of a cholestatic injury. The IgG was negative. Autoimmune serology was negative. Viral serology were negative. Everything was negative. But at that time, she has COVID. Okay, so let's see what COVID has got to do with this. So this is a biopsy. And here again, we are very fortunate that we usually don't have to worry about getting an adequate amount of biopsy. So on low power, it looks a little bit similar to the other one, just that you don't have a lot of phototransls that are showing the inflammation. And I'm deliberately staying on low power here because on low power, you can also start seeing that there's something wrong. There's a lot of holes here. And as we go deeper down, find that those activity again are limited to the portal tract. And now you begin to see something here that is very subtle, and you are not going to see this in a lot of textbooks. When you start having problem with draining bile, the first thing the hepatocytes around that area do is to undergo some kind of biliary metaplasia. And on low power, what they look like is that they start looking blue. So remember, the bile ducts themselves, they are more blue than the hepatocytes. What you see here is that you see hepatocytes that are beginning to look more, have that same color of the bile ducts. Not quite, but when you go down, you find that they're still the hepatocytes. So if I were to show you the CK7 on this one, some of these are also going to start picking up CK7. And so we say that they are undergoing biliary metaplasia, and that is usually the first thing the liver does. So if you train your eyes on that, you might be able to pick out a biliary disease even from high altitude because you just start seeing some of those periportal hepatocytes. If you don't see them, it doesn't rule out that you are dealing with a biliary disease. But for the sake of our time, so let's start with some of this. So this is the most inflamed of all the portal trials that you see here. So let's look at what the inflammation is again doing. Again, it's right there in the portal tract. There's a little bit of expansion. Now, we don't see as much of the ductular reaction as we saw. What we see here now are the bile ducts that are sitting right there where they need to be. And again, you see some of your macrophages here that are there, but these are true bile ducts. This is the corresponding hepatic artery right there. It's a little bit twisted to the side, the same size, and you probably will see another hepatic artery somewhere here. Now, I don't think these are many bile ducts in the portal tract. You can see more than one bile duct in the portal tract. But what happens usually is that when you cut the biopsy in a longitudinal pattern, you don't always catch the same bile ducts along its entire length. So sometimes because it's a little bit wiggly, you can capture the same bile duct at multiple points and it looks like each one of them is individual. But I think this, if you keep on doing levels, you see that this is more or less the same bile duct, most likely. I can't prove that, but I think that's what it is. But they are sitting right in the center. So those are not reactive ductules, unlike what we saw before that tends to hug the interface. So you see a little bit of inflammation right there. And then as you go down, you see more or less just, teeny weeny thing, but the small ducts are there. So we don't have ductopenia like we saw in the other case. Let me go to another one that shows the same thing. So just a little bit of inflammation going on in the portal tract. You don't see much of the things that you saw. Now you start looking at some of these bile ducts that they look a little bit unhealthy. So the cytoplasmic is eosinophilic. The epithelium is beginning to look different sizes. So a normal bile duct, ideally, all the epithelial cells are the same size. They are evenly distributed, and you don't see this cytoplasmic eosinophilia. So we begin to see it there, and you start wondering, okay, what is going on with the bile ducts here in this case? And as you go into the portal tract, you see some lipofuscin here and there, but this patient also has some, parenchyma cholestasis already. And I'm not sure I'll be able to pick out. So there are probably some hepatocytes now that are already accumulating some bile inside them. Here's another portal tract that shows that, again, look at how the nucleus are no longer even, and now you are beginning to see some of the nucleus is even lost in that. So this is very subtle, a little bit of bile right there. So this is one of those subtle diseases, and you just have to go with the fact that, again, there's no parenchyma inflammation, so we're not going to go towards hepatitis here. So why would the bile ducts begin to look sick in a patient that has rheumatoid arthritis that is being treated? There's really nothing in her that would suggest there's been no drug change. The same medication she's been using for rheumatoid arthritis all the years is what she's using. So this is when it takes us to something called COVID cholangiopathy. It's a very poorly understood or recognized entity, but clearly there are a lot of reports about COVID cholangiopathy right now. Most of the cholangiopathy cases that has been reported seem to affect the large hilar ducts. And patients just come in with jaundice because of COVID infection. And some have also been reported in patients that recently received the COVID vaccine, cholangiopathy. And the reason why people believe, and I believe, and I'm one of those people that believe that it is a real entity, is because when the patient recovers from COVID, after a while, gradually, the cholangiopathy process also recovers. So when you just look at it on raw power, I think the evidence here mostly has a lot of weight with the biochemistry. So a patient that just developed, ALP of 600 with jaundice and has this sick bile ducts without a lot of inflammation and everything. This is another area. Look at how ugly those bile ducts. So they are not disappearing, but they just look sick. In another context, we say that they look senescent. Okay, this is another one. Just looking like he's just on his way out, compared to a more normal, component of the same bile duct. So COVID cholangiopathy, again, it begins in being able to recognize that whatever is going on here, first is a cholangiopathy process. If you don't reach that conclusion, you are not going to be able to sort out what are the, possible causes of this patient's problem here. So this patient, they really didn't do anything. They just were very supportive. She recovered from her COVID. And over several weeks, the bilirubin improved and the alkaline phosphatase is still somehow high. But the last I checked, I think the alkaline phosphatase had come down to about 200. So that might take a while to recover fully. But the important thing is that it's going in the right direction. So try and do, if you do a Medline search, you're going to see a few examples of cervical angiopathy. Unfortunately, a lot of those reports also didn't come with biopsy, to be able to put side by side. So maybe someday we are going to get our own series together because this is not the first one that we've seen actually. Probably get the series together and be able to share that. These are just very subtle cholangiopathic injury, but then they translate to very significant biochemical abnormalities in this patient. If she was taking some drugs that could cause cholangiopathy, that will also come into the mix. We are going to have to think of is, can this be a drug-induced cholangiopathy? And it will look like that exactly, especially some of the antibiotics that we commonly are exposed to can cause exactly the same pattern of injury. Okay. If you have a question, just say it or type it so that I don't know. But I want to finish the last two, and I have just about 5 minutes. So let's see how that works. So the last two patients are the same story, and this is a 60-year-old man. So this is now a post-transplant liver, and I didn't want to discuss transplant here, but I think this is a very good illustration for what I wanted you to see. So I'm going to show you this. This patient has rejection. So that's not the issue. The enzymes, though, if you look at it, it started with being very cholestatic, but also a lot of transaminase elevation. Bilirubin was rapidly elevated in this patient, which is something that is unusual after 3 years post-transplant. So here is that biopsy, but the one that I really want to show you is the last biopsy. So this is the case 4, and this is what the rejection looks like. Oh, no, I need to show you case 4 H&E. So, okay, this was mislabeled. So this is H&E for case 4. For some of you who look at liver transplant, you easily recognize that, again, you get all the portal inflammation here. Again, nothing in the lobule. It's just the kind of injury you want to see. It's a little bit mixed. Here you see some neutrophils. In other areas, you might see some eosinophils, and see the bile duct is right in the center there and it's captured there. And again, you look everywhere, it's the same pattern. So what happened, I think this man for some time, this time was sick and he stopped taking his medication. So he developed some of this injury. And we called, rejection rapidly, and this patient was treated. Now, this is the one I wanted to show you, case 5, because this is the same biopsy from that patient. So after they treated, he responded, and the ALP came down slightly, 460. So always know that when you have a chronic biliary disease, even when you treat it, alkaline phosphatase doesn't respond as rapidly as the transaminases usually do. So it might take a while. So, but because the alkaline phosphatase was still 460, they decided to do another biopsy, I think about 2 weeks later. And the bilirubin was less and everything. So if you look at this new biopsy now, again, it looks like some of the ones that we had looked at, especially that COVID cholangiopathy. And again, look at those blue hepatocytes in the portal tract that I say you should learn to train your eyes on. So that's the hepatocytes trying to protect themselves by undergoing biliary metaplasia, which is more able to withstand, bile salt. So that's what happened. But if you look at this, if I didn't give you the previous story, you say, oh, Dr. Adeyi, this is similar to what we've been talking about. You see some reactive ductus, you see a little bit of inflammation, some neutrophils. This is a biliary disease. Should we be looking for obstruction, or is this a small duct disease and everything? And you will be right. So the reason why I put this one is to close the gap and say that sometimes a biopsy can look like a biliary disease. If another disease is being treated and that disease is recovering, During the recovery phase, the residual changes might begin to look biliary. So you also want to take into consideration of what went before. So if I didn't get any history, if I got this biochemistry fresh and I say, oh, alkaline phosphatase of 460, biliary disease, bilirubin of 3.8 milligrams, and I see this, this is a biliary disease until proven otherwise. Again, you see the expansion, you see the edema, you see the ductular reaction now, and you see the neutrophils that go with the reactive ductus. This is what a biliary disease will look like. But I know this is not a biliary disease because I know what happened just 2 weeks ago. So this is not an unusual picture for this. So I just wanted to close there that sometimes it might look biliary, but it might have a different explanation. So the diagnosis we gave them here is that we said that this is a resolved rejection, but you still see, so now when the rejection resolved, the liver is going to try to remodel and to replace whatever it lost. Okay, including some of the bile ducts that were injured before. Now there's going to be some reactive ductus, and for a while, it's going to look like the portal tract is in trouble. So when do I make a diagnosis of cholangitis lenta? So great question. So cholangitis lenta is a morphologic picture that includes, so the patient usually will have been a sick patient and will have presented with jaundice. And when you go to the portal tract, you will see something similar to what I'm showing you now. But the cholestasis in that is usually in the middle, right in the lumen of the bile duct. And the bile duct will look like they are atrophic and withered, but then they will be filled with bile. Yeah. And so we call them cholangitis lenta. And then you can see some of these neutrophils because most of those patients have sepsis, or some of them are very sick, debilitated, and they're undergoing a lot of antibiotics, and some of them may have ascites with bacterial peritonitis. So cholangitis lenta is usually associated with very, very sick patients. And the histology picture that makes it cholangitis lenta is actually that dilated dot with some bile ducts inside them. You are probably not going to see this degree of ductular reaction in that context. And again, that is going to look like a biliary disease. But in cholangitis lenta, the alkaline phosphatase actually may not be elevated because the problem is not really liver problem per se. It's more of a systemic problem that the liver is also one of the organs that are manifesting that systemic illness in this patient. So I wouldn't use the word cholangitis lenta in this patient, but some of the features you see here may also be seen with cholangitis lenta in a different context. Okay, I think so. This is the last case that I saw, that I have to share with you. But at the end of the day, what I just want to share, what I want to emphasize is to try to recognize when something is not hepatic. And biliary is one of the commonest in such conditions. We have other diseases that can have inflammation. So you can have a patient with granulomas in the liver. And I try to stay away from calling granuloma hepatitis because most granulomas are actually not liver diseases. Again, most of the time they are systemic diseases where the liver is one of the organs that are affected with the granuloma. So you don't want to send them looking for causes of hepatitis. You want to send them looking for causes of granulomas. Because when they find the cause of the granuloma, they are going to treat, the liver is going to recover, the lymph nodes will recover, the lung will recover, and everything else involved is going to recover. So try to be very selective about when you use that term, hepatitis, and find, could this be another process that is going on? And the biochemistry, the patient presentation is usually very, very helpful there. And the last word I would say that even if you mischaracterize things with hepatitis, a very good hepatologist is probably going to call you back and going to say, no, what you are saying does not match what we see biochemically. Can you look back and take another look to it? So, but you don't want to get into that point before you start, making the right call. So I'm going to stop there to see if there are more questions or comments. We went 4 minutes past, so sorry about that.
A wonderful presentation, Dele. Thank you so much for opening our eyes to this distinction and your approach to evaluating the portal triads and the biliary system is very, very helpful to us.
Yeah, thank you. I'm glad that you liked it. And thank you again for having me. And for those of you in the US, I really appreciate you having to wake up just to listen to me. Now you can go get the rest of your coffee.
I'll just point out that our next session will be February 16th. And as I indicated at the top, we'll have another guest professor, Dr. Shweta Agrawal from the University of New Mexico, who will be with us to talk about sinonasal lesions.
Okay.
Well, I don't see any questions, Dele. Thank you so much again. This has been wonderful.
I think there's something in the chat. Is that? Oh, okay. Thank you. Okay, that's not a question. Yeah, you're welcome.
Yeah.
Thank you, guys.
All right. We'll sign off.